Dear colleagues, welcome to our webinar focusing on the new routine for radiology post-coronavirus peak. Together with my colleagues from radiology, Stefan Niehues and Thorsten Diekhoff, section head of CT at 2 different locations of the Charité, as well as Professor Fischer, head of the Interdisciplinary Ultrasound Center, we would like to share our strategies and experiences in this topic. And since we expect an international audience, please let me give you some short information about Berlin. Berlin is located in the eastern part of Germany. It is the capital of Germany, and it is the largest city of Germany. However, with 3.6 million inhabitants, it is not that big compared to other mega cities. In Berlin, we have one university hospital. This is the Charité. It is Germany's largest university hospital, since during the last years we had the merger of 3 different university hospitals, the Charité Central, the Campus Virchow-Klinikum, as well as the Campus Benjamin Franklin. Altogether, we have more than 14,000 employees, 3,200 beds, and interestingly, exactly at this place where the Charité Central is located, more than 300 years ago, a very, very small hospital was founded far outside the city walls to fight against another epidemic, and this was the plague. Nowadays, we are fighting against COVID-19 pandemic. So the situation was as follows. In Europe, initially, we thought that the coronavirus will stay in Asia. It will be an Asia epidemic, but it might not come to Europe. However, end of February and beginning of March, we recognized, no, the coronavirus is approaching Europe and initially hits the northern part of Italy severely. This is not a good news, but the good situation for Germany was that we were aware the virus is coming and we had 2 weeks left to get prepared for the coronavirus. And this is the situation of Berlin and the surrounding state, Brandenburg, altogether around 6 million inhabitants. And as you can see, at the beginning of March, we had the first coronavirus patients in our ICU beds. And this continuously increased, and at peak time, mid of April, we had 220 COVID-19 patients in ICU beds, and thereafter you can see a continuous decrease, and now it's significantly lower. And in our overview, we would briefly mention how we managed the pandemic, or let's say how we tried to manage the pandemic. And then we, of course, we will focus on the topic of this webinar, the long and really challenging way back to normal. In March, the clinic operations were reconstructed to be prepared for an increase in COVID-19 patients. First of all planned surgery, operations, interventions have been postponed to keep the intensive care unit beds free for coronavirus patients. And we increased the capacity up to 364 intensive care beds. And during the corona peak, we treated 96 COVID-19 patients in parallel in the ICU ward, including 13 extracorporeal membrane oxygenation, and in addition, 156 patients with mild symptoms of COVID-19 in the intermediate care. So, for example, you can see this building. This was in the past used as a hospital building. Then the administration took over, and now it was completely evacuated. And again, 135 beds were installed, most of them with respirators to be prepared and to increase the number of ICU beds. As you can see on this slide, everything was prepared in case that we have much more patients with coronavirus infection. So again, we have a very high number of ICU beds, and even in the peak time, we did not reach the high number of ICU beds, so we are quite comfortable with having enough capacity. Currently, we are treating 28 patients in ICU beds and 12 patients with coronavirus infection in intermediate care. However, this was not the only measure which was taken. So as already mentioned, we increased the reserve capacity of ICU beds by postponing planned interventions, and we created a safety concept together with the fire department how to arrange the intensive care beds capacity in Berlin and in the whole area, including offering telemedicine service to other hospitals if required. And as already mentioned, we evacuated a whole building and reserved this building only for coronavirus infected patients, including intensive care unit beds. And besides this, of course, we try to take care about all the employees by separate screening units for the employees at each of the 3 campuses. However, the Charité was flooded by hundreds and thousands of patients who are scared if they may have the infection, who have symptoms. And so the Charité, together with the Robert Koch Institute, created a Corona app, the so-called COV app, which has been translated in several languages with about 15 easy to answer questions, so that the citizen at home can answer these questions to decide if they should stay at home, go to their primary care physician, have a PCR test, or should go to the emergency room. In addition, a COVID-19 research board was founded to increase the knowledge about the new coronavirus, its health-related consequences and therapy options on all the latest scientific findings, news, and publications. But now let us change to the focus of this webinar, and this is the post-COVID-19 scenario. What happened with the intensive care sector? By law, at least 25% of the intensive care beds have to be reserved just in case of a second peak. All the other ICU beds can be used, let's say, for the standard normal treatment. Another very important aspect, and as you can see here, again, for Berlin, this is the capacity in the whole city, more than 1,400 ICU beds, and currently only 44 COVID-19 patients are in ICU beds. And on the right-hand side, you can see now most of the ICU beds are used now for standard care for all the different patients, different diseases. 4% only for COVID-19 patients, but still at least 25% have to be reserved just in case that there might be a second peak. The safety concept is one of the most challenging one from the point of view from radiology, because we have to handle the workflow of so-called standard or normal patients and COVID-19 patients in parallel. So for example, regular patient service has increased already to about 90% of the standard number of patient care. Usually we have about 1,700 individual examinations per day. During the lockdown, it dropped down to 850. Now we are up to 1,500. During all the time, including lockdown, we offered all procedures, including interventional radiology. And now again, we have outpatients, inpatients, of course, emergency cases, follow-ups and screening. And basically, every patient coming to the hospital, in principle, might be an infected patient because nobody knows exactly. So therefore, several measures are still taken. For example, the staff and the patient have to wear a mask, distance even for the reading room. So in the reading room, for example, here in CT, we have this plastic divider to keep this social distancing. Another very challenging aspect for radiology with so many patients is the patient scheduling. Of course, in the past, the patient gets a date for the examination, going to the registration, and then they were asked, please have a seat in the waiting room. But nowadays, the waiting room space is limited to keep the distance. It should be not crowded or overcrowded. And so the scheduling of the patients is not that easy, and the patient should leave the department immediately after the examination, and the patient should have only one accompanying person, not the whole family or something like this. In addition, we have an optimized hygiene concept for every examination, and Dr. Niehues will talk a little bit more in detail of this because it takes extra time. So what's about the intensive care building? The administration is back from home office. Finally, this is a good result because if you have them on site, many things can be arranged more easily and faster. So what's about the employee screening? More than 7,500 medical staff employees have been tested on a voluntary basis, and only 0.5% were tested positive. Most of them are asymptomatic, and less of all tested persons, less than 2% showed antibodies. Yes, there might be some negative results, however, false negative results. However, these very low numbers indicate that the measures taken by the hospital worked quite efficiently. In addition, the Charité is asked to consult the Berlin government in view how and when to lower the restrictions. And of course, for the future, we should increase our research activities. And one aspect is to create a national digital platform to be prepared in case of a second strike and future pandemics. And at the end of this presentation, I will come back to this topic. And now I would like to hand over to Stefan Niehues in the CT section of Campus Benjamin Franklin.
So thank you, Professor Hamm. I'll just give you a small piece of information how we managed this pandemic in the south of Berlin and how we are going to cope with whatever the future is going to be like. So I'll just talk about all those measurements which have been done, how we managed to provide continuous care, and how we are being prepared for whatever the future is going to show to us. You just learned that we have 3 campuses, and I'm located here in the south, and I'm going to report on whatever this hospital took to fight this pandemic. And as you can see here, the hospital is placed just around some green, and its architecture is very special, and I'll come back to this in a minute. What we have done in the past, you have heard already a little bit about, is extensive and repeated testing of personnel and staff and the patients. We initially canceled all elective procedures or postponed them at least, banned vacations and official trips to keep the staff being ready and available in the hospital. And we had separated the patient groups into COVID patients, suspected COVID patients, and non-COVID patients. We have stricter safety regulations and applied a massive focus on hygiene, and which turned out to be very, very important is the massive supply of information given to the staff and the patients, and of course provide enough protective equipment for all. This is how it looked like in the peak of our pandemic, and it's still the way it looks like today. You can see that all of our patients in the front desk have been asked to keep distance, at least 1.5 meters, and they are asked to wear masks. You can also see here that the glass windows from the front desk are kept closed so that there is no direct contact possible. What turned out to be more complicated than you could expect is how to wear a face mask. And it's like each and every day that we come across patients who wear their masks, some like this here. So like if their chin is going to spread out the virus, it's up to us, to the complete staff, medical staff and non-medical staff, to keep our patients informed how to wear their masks so they wouldn't spread the virus if they had one. For taking care of our patients, CT has proven to be a very fast and helpful method in peak times, because still until today, the waiting period until we get the results from the PCR can take up to hours. And sometimes we have even a discrepancy between the clinical appearance of our patients and the PCR testing. So we're not sure if this testing is a false negative or not. So CT has proven to be helpful in triaging those patients and then separating those patients already at the entrance of the emergency department. For the department, the CT and cinema, we do the same for the conventional imaging or the MRI department. We separated our technicians into one part who is taking care of the patients and is wearing the complete set of personal protective equipment. And the second part of the personnel, the second group, who is just within the control room. They're still wearing their masks, but they don't have any contact with the patient or with the other part, with the other group of our technicians. So if one gets contact to the virus, they won't spread within the radiology department or maybe even further to other patients being seen next. And we do the same for our doctors. In the reading room, we have built up some easy barriers so that we can keep distance and no one is just running into the reading room asking to see some kind of report or imaging. And so we keep the distance at a high level, and this is something which we are going to continuously live until we have some kind of long-lasting solution for COVID-19 patients. Social distancing is not just only staff, but also just the complete hospital being affected. We have changed our main entrance. There's security personnel staffed in the entrance. You need to have your staff badge showing to the personnel security members just to pass through the entrance, and patients need to show that they have an appointment with one of the doctors to just enter the hospital. And distancing means, as we have just learned from Professor Hamm, that just each second seat will be available to our patients. And we also took measures that in other areas of our hospital, the personal contact will be limited. You can see a 2 meters distance to be kept, and persons are asked to use separate ways to come to different rooms. And sometimes it feels like a little bit odd, like this picture is going to show you. This is something I personally feel like it's like having an exam back at school, but it's just our cafeteria where you can see the tables are just single seated, just showing into one direction. It feels really strange of having your meals in there, but it's something we all have to deal with. Measures which have been shown to be very effective, you can see here exemplified by our ways in the emergency room. This is a sketch of the emergency room. Here at this point, patients can enter the emergency room and they have been triaged at the entrance, and the radiology part is just in the middle of the emergency room. And we have separated the areas of the emergency room into 3 areas. The green area over here showing the area of non-COVID patients, which are located here and who are treated in the green areas. We have the red areas where the COVID-19 positive patients are being treated, and we have a COVID observation area. And as you can see, as some of the rooms are not colored, we can expand each and every area depending on the demands of the patients by a daily basis. It turned out to be very effective. And so we did the same with the hospital itself. You can see here another photo, and you can see that we have 2 areas where the COVID-19 positive patients will be treated. And in the direct opposite direction, we have an area where the COVID negative patients can get their treatment. And we have a separated area of those patients who are under suspect of having COVID-19, and they will be placed in these wards. And after the PCR testing has been performed, sometimes repeatedly, they can be moved to one of those 2 locations to get further treatment. There are, of course, many other diseases which tend to be forgotten in the first peak, but those patients still need medical care. So we had a continuous tumor therapy in terms of surgery and oncology treatment. And of course, we continued to provide emergency service in a 24 hours, 7 days a week service. We keep the staff informed all times. And after the main peak has been reached, we started to provide full service but we needed, and we are aware that there is a high chance to have a second strike, a second peak. So we always are planning to be able to return to a COVID focus within 24 hours. We keep to have a relentless separation of all the suspected or maybe positive COVID patients from the non-COVID patients. And the hygienic workflow, which we continue to have, is something which remains. Still, we do PCR testing of all inpatient students and of all those persons being administered to the hospital. And we keep our patients and the staff continuously informed. In terms of hygiene, which turned out to be very, very important, we had practice tutorials with the hospital's Institute of Hygiene. So we simulated CT, conventional radiography, or MRI being supervised by the colleagues from the Institute of Hygiene, and they told us where there might be room for improvement. And we do this in a continuous manner to keep aware and keep being alert not to spread any virus if another peak will appear. Hygienic workup also means that we need to clean all areas which have patient contact. And we started with incidine, which takes 15 minutes of residence time between each patient. We needed to change to Descosette, which works in the same way, good against COVID and other virus, but it just takes 5 minutes. So we were able to meet the demands for CT and MRI and conventional imaging, because 15 minutes between each and every patient will just break all barriers, and the waiting time in the emergency room and on the different wards would just being too long. We have learned very much in this kind of crisis. We have an increased awareness of hygiene, and we built tough interdisciplinary teams. We established regular meetings, not just only within the Department of Radiology, but even beyond. And we learned to create more flexible solutions. One of them, for example, being the Berlin University Alliance. Many institutions, many excellence clusters working together just with one major goal: to fight against this pandemic. And also we learned again that crisis also could be a motor. It took just 4 weeks to get a CE mark for an AI tool, which never anyone thought that would be possible. We established virtual meetings as the new standard. I think this is something which will remain for the future. And not only in China, also in Berlin, we were able to build hospitals, not just within months, but also in days or weeks. For future aspects, I just can encourage you to use any effort to fight this pandemic, work together and build new teams who complement each other, and use all resources available. But one of the most important things, please enjoy still being a radiologist and continue to take care of our patients. Thank you so much.
Welcome, ladies and gentlemen. Thank you very much for having me. My name is Diekhoff, and I want to shed light on the current COVID-19 situation from the perspective of a radiology department that is scattered over a campus and present the challenges that go along with it. I want to briefly discuss the measures that were taken during the crisis and led to the current situation, the preparations that we do for normality and for a possible second wave at our campus. So, as you already heard, during the crisis, the Charité established over 130 new beds, most of them ICU beds, in a building that was previously used for administrative purposes. We have a conventional ICU and emergency room department across the street, and we have an infectiology department in a completely separate building. And similarly, at our campus, the radiology department is dispersed. That means we have a CT scanner in the emergency room, we have a CT cluster in a different building, and we have a fourth CT scanner in the infectiology department. And now, as you can imagine, if all the patients that come from the COVID clinic come to the CT cluster, it would be very hard to separate the COVID and non-COVID patients. And what we did is we asked the nuclear medicine department, that is one stair up, if we could use their SPECT CT scanner to scan the COVID patients and thus have the CT cluster COVID-free. And this is, in my opinion, really important to separate the COVID and non-COVID patients, if possible, spatially. That means you have a dedicated COVID CT and dedicated non-COVID CTs. Or when this is not possible, to use fixed time slots for COVID patients to separate the non-COVID patients from the patient with the virus. What has changed in the last weeks? As you heard already, the numbers in Berlin declined, so the COVID clinic and the SPECT CT scanner are no longer in use. Also, we have no COVID patients in the conventional ICUs, and all the patients are focused in the infectiology department. And this is a situation which we can handle quite well. We are used to it from other infectious diseases, such as tuberculosis and so on. In my opinion, the challenges present in outpatients that might carry the virus unknowingly and arrive in our department. So we have to ensure that the patients are well prepared, they keep the physical distancing, and we have to be aware that they might occur with unexpected CT findings, and we have to manage them. This is the situation that we do not want to have. As you can see, the patient is in the clinic without the proper distance to the other patients. He has more than one person with him and surely does not wear a mask. So when the patient arrives in our hospital, he has to wear a mask. If he does not have one, he gets one from our staff. And one thing is important, those masks with a filter on it, they are not allowed in our institution because the filter prevents the virus from getting inside the mask, but not outside the mask. So if the patient would be COVID positive and sits in the waiting room with such kind of mask, he might spread the virus in the waiting room. So the patient is requested to change the mask or wear an additional mask on top of the filter. The ideal situation would be that the patient enters with a mask on it, has only one person with him, and they both keep the proper distance to the other patients. Furthermore, we plan 5 to 10 minutes longer for each patient to ensure proper disinfection of the room. As you heard in the waiting areas, we have marked every second seat so that the patients do not sit there and keep the proper distance. Therefore, we had to establish new waiting areas, and we have medical personnel or medical students that assign the patients to the proper waiting areas. When the patient is in our department, we want to make sure that the time he is in the waiting room is as short as possible. So when the patient comes too early, he's requested to leave the department and come back when scheduled. We try to have the preparation time as short as possible, so we have only a brief oral information. Inpatients arrive with an IV, and for the time being, we have no oral contrast for outpatients because we do not want the patients to sit 1 hour in our waiting room and drink the oral contrast. The patients have to leave directly after the examination, and the staff and the patients wear surgical masks at all times. So we treat each patient as a possible COVID patient, and we are aware that the radiology facility has by far the most patient contacts and is therefore prone of spreading the virus. So when a patient with suspected or confirmed COVID-19 comes for a CT scan or another examination, we take the usual measures. That means we use the more time-consuming disinfection of the whole room. The staff wears masks and protective gloves and so on whenever in contact with the patient. Everything in the CT room is completely covered. So also the CT scanner and the controls so that we limit contact and surface contamination. Also, when we are not in direct contact with the patient, we wear a mask. When another person is in the room, we use regular disinfectant for hands and surfaces. And as you heard, we install such plastic shields to separate workstations that are nearby. One thing is important for me as the last point, and this is unexpected findings. You will encounter unexpected positive CT findings or suspicious CT findings in patients that are not aware that they have the infection. So what we have to make sure is that we get those patients and that we screen and see the CT scans as soon as possible. Remember, the patient already left directly after the CT scan, so the physician has to take care that the CT scan is properly reviewed. We have to make sure that we have the contact numbers of the attending physician, not the nurses or the ward, but the attending physician, and the contact numbers of the patient so that we can contact him if he has suspicious CT findings for further workup, or if one patient he has had contact in the waiting room is positive. You have furthermore to insist in further workup and probably isolation of the patient if you have positive findings or suspicious findings in the CT scan, even if the clinician says it's not likely that the patient has the infection. And we have to also be aware that in really low dose scans, we might miss beginning groundless opacities, such as in this case, where they are really hard to see, and to see the changes reliably, you have to use intermediate dose, a sharp kernel, and thin slices to get the COVID findings. So what happens in case of a second wave? If you heed to everything that I told you in the last minutes, I think this is not a problem. In our case, we would just reactivate the COVID clinic and the SPECT CT, and otherwise to just everything the same that we do now. And we will try very hard to keep at least one CT facility free of COVID and therefore safe for other patients. Thank you very much for your attention.
So, ladies and gentlemen, welcome from my point of view today and what's next from the ultrasound business. First of all, I will briefly outline the measures taken by Charité as well as the measures taken by the Department of Radiology, including the role of the interdisciplinary ultrasound center. And last but not least, we have to going back to normal also in the field of ultrasound. For us as the ultrasound center, this was a very, very important measure to have a dedicated COVID-19 emergency unit as well as a dedicated ward for COVID-19 patients. That means we can have a parallel examination of these patients. And from the ultrasound point of view, all isolated patients are examined at the bedside. This is a key feature in my opinion, because you have to save your own stuff. And of course, we have also these contact restrictions in terms of scheduled examinations of outpatients, and of course, limited access to our waiting areas, as you can see on your right. But what is the role of point-of-care lung ultrasound in COVID-19? So please first have a look on your left. This is the great spotted woodpecker, uses only its beak to make a hole in a tree, and that's definitely point-of-care. So we don't have to use these bulky high-end machines on your right. This is our schema to handle COVID-19 pneumonia. Of course, these patients underwent immediately a chest CT examination. And if there is a suspicion of a viral pneumonia, these patients go to a dedicated ward for COVID-19. But all the follow-up and complication imaging is done at the bedside based on ultrasound. And of course, here we have a clear indication for follow-up CT scans. And as you can see on your right, we have organized the training in our ultrasound center. That's an overview on our center, including 12 disciplines and 5 columns. Of course, this center is headed by the Department of Radiology. And as the ultrasound center already had a close cooperation with the team of emergency physicians headed by Professor Möckel, before the pandemic, we intensified training in lung ultrasound for physicians of other specialties. Hardware is important. On your left, COVID positive, we use dedicated scanners and rooms for COVID-19 patients. Disinfection with suitable clothes that's clear, and a work list could be generated via VLAN interface, and reporting could be supervised by radiologists via our own hospital PACS, once again, to save our own stuff. And on your right, COVID negative, phone registration on your scheduled examination of outpatients, and automated disinfection after all interventional procedures. As you can see on your right, the combination of the E800 from Canon and the Trophon system. That's a view on your left on our dedicated ward for COVID-19 patients, the so-called Charité Campus Clinic. And there we used only these small portable ultrasound devices, easy to disinfect. And in addition, we established a structured reporting based on a common standard. You can use web material for training, but also your own cases. And that's an example of ground glass opacities in a CT scan and the same patient with these confluent B lines or a more aggressive portion of the lung where you can see small consolidations as well as B lines and confluent B lines. Next step, you have to accept an examination protocol for lung ultrasound. And so therefore, all cosmetic filters are off, for instance, frequency compounding. The focus point should be adapted to the pleural line. The gain should be adapted. We use a very high frame rate and a penetration depth of 14 centimeters. On your right, a 6-point scaling per hemithorax. In the mid-clavicular line, the anterior axillary line, the posterior axillary line in the intercostal space. Our first training case, first of all, this area, A lines, represents regular lung pine tumor. And of course, you can see the small consolidations very well, good correlation, discrete B lines, and once again, pleural thickening in combination with confluent B lines. Second case, and I think that's the actual situation. So we get a CT scan on in April this year, and the follow-up is done at the ultrasound 14 days later, and we see a clear disease progression in terms of confluent B lines representing the edema. We see a positive air bronchogram, well visible, and also a pleural effusion. And the third case, complication imaging, that's a situation 39 days on ICU, increasing C-reactive protein levels, and the lung ultrasound with finding or suspicion of a lung abscess, which was confirmed by the CT scan. Going back to normal, ladies and gentlemen. First of all, what's next? I think we need also guidance for the conduct of ultrasound examinations and clear and strict indications. And as you can see on your right, this is an interesting case from last week, a bladder diverticula with a transitional cell carcinoma. In a CT scan, MR scanning, overlay of both modality and the actual situation based on contrast-enhanced ultrasound, where you can see clearly the necrotic portion of the tumor after 2 cycles of chemotherapy. So in summary, you need a concept for the parallel examination and ultrasound of normal patients and COVID-19 patients. All patients newly admitted to the Charité, for instance, for an operative procedure, are currently being tested. Basically, examiners wear surgical masks for all patients, and surfaces and transducers will be disinfected after each examination. Physical distancing and airing rules, that's clear. And on the way back, we are around about 85% of the usual capacity of the ultrasound center. That's a view in our procedure room where you can see this is a prostate cancer suspicion. And on your right, this is the automated disinfection and our high-end stuff. Going more in detail in the case, you see an area in a T2 weighted imaging of the MR scanning, a good corresponding finding here with an aggressive cancer with hypervascularity based on contrast enhanced ultrasound. And on your right, this is the same patient immediately before the puncture procedure will start. We use the SMI technology to see the vascularity of the tumor and then picking up the needle tip in the exact positioning of this tumor area. For the whole concept, we get the prize for patient safety in May this year. So from my point of view, congratulations to the whole team of Radiology in the ultrasound center. And to you, I have to say thank you so much for your very kind attention. Thank you.
So colleagues, thank you very much for your attention. And at the end of this webinar, I would like to give a short closing remark. This is an interesting evaluation from Florian Fleckenstein from our department, showing the individual examinations during work days and during the weekends for the 2 years 2018 and 19. And as you can see with the red line, we have a high number of individual examinations per day before the lockdown, and then a significant decrease of number of examinations during the lockdown, and now another increase. Now we are up to about 90%. However, very interesting is the next graph, indicating overall we had a decrease to 60% compared to normal times. However, interestingly, we had a decrease in examinations in all the different subspecialties. It's not only orthopedics or surgery. There was a decrease in examination for stroke, myocardial infarction, or even oncology. And this is surprising because even during lockdown, there might be not less stroke cases or myocardial infarction or oncologic patients. So this might indicate that the lockdown may have postponed or missed early detection and early treatment. So we are aware of having more severe diseases in the coming months. Another topic is the PCR testing. PCR testing is important, but it's not the holy grail, as it has been shown that PCR testing, depending on the prevalence, we will have false negative tests in about 20% of the cases, as published in the New England Journal of Medicine and a recent paper from Watson in the British Medical Journal. And as we see this sometimes from day to day, there are patients with a negative PCR test, but symptoms, and then they receive a CT of the chest, and we see the typical findings of COVID-19 infections. So imaging might play a more important role in the future, and therefore we are creating a national platform to fight COVID-19, and these are the goals: to establish imaging strategies and analysis methods for primary COVID-19 diagnosis, imaging strategies for personalized risk assessment, therapy control, and post-COVID-19 changes, which will be important during the next months or years, the changes in the lung due to COVID infection, a comprehensive quantitative pulmonary imaging tool, and a long-lasting collaboration network for future pandemics with a combination of all medical university hospitals in Germany. Finally, I would like to quote Professor Frey, member of our executive board. He said, "We will continue to monitor the situation closely and, if necessary, make rapid adjustments." And I think this is the most important, to make rapid adjustments if the situation is changing, because the protection of care of our patients and employees is the top priority in all our decisions. With this, I'd like to thank you all for your attention, also on behalf of my colleagues from the Department of Radiology of the Charité. Thank you very much.